Okay, let's unpack this. Have you ever looked at a medical bill and felt like, I don't know, you needed an advanced degree just to figure out what it means, like deciphering ancient hieroglyphs or something?
Oh, absolutely. You're definitely not alone there.
It's this really dense, opaque world of codes and charges, and honestly, it can feel like you're trying to read a completely foreign language, one written just for insurance companies and, billing departments.
Right, it's not exactly user-friendly.
But what if I told you that by the end of this deep dive, you'd not only understand some of that language, but you'd actually feel, well, empowered by it, confident enough to question things, maybe appeal, and really navigate your own healthcare finances?
That's the goal.
Today, we're diving headfirst into something that impacts pretty much everyone who ever interacts with the healthcare system:
Oh.
medical billing denials.
A big one.
And these aren't just, technical details for the doctors or hospitals. Understanding them offers immense clarity and, frankly, empowerment for you, whether you're a patient, maybe a caregiver, or just someone trying to make sense of your own explanation of benefits.
The EOB, yeah, the key document.
So our mission: to turn those complex, confusing denial codes into understandable nuggets of knowledge, help you feel truly well-informed, and, I promise, a lot less overwhelmed. In fact, let's imagine our friend Sarah. She just got a bill after a routine checkup, right?
Yeah.
It's way higher than she expected.
Happens all the time.
And on her EOB, she sees this cryptic code, CARC15. What does that even mean? Well, by the end of our deep dive, Sarah and you will know exactly what that means and, crucially, what she can do about it.
What's truly fascinating here, I think, is how these seemingly small, often kind of overlooked codes, they hold the key to understanding just enormous sums of money and really critical processes within the whole healthcare ecosystem.
It's not just pocket change we're talking about.
Not at all. Denials are far from a minor hiccup. They are a massive, pervasive part of the medical billing landscape. I mean, to give you some perspective, industry estimates often suggest that somewhere between, say, 10% to maybe even 20% of all medical claims are denied on the first submission.
Wow, 10 to 20%. That's huge.
It is. That's billions of dollars just stuck in limbo.
Yeah.
And that directly impacts not just the provider's revenue cycles, their ability to operate, but crucially it impacts patient financial responsibility and, peace of mind.
Yeah, the stress factor is real.
Absolutely. So mastering these codes is critical, not just for the billing office trying to, get paid, but for anyone looking to identify precisely why a claim wasn't paid, understand the root cause, and then take timely, effective action. And this understanding, it can ripple out significantly. It directly impacts patient experiences, ensuring that the proper care isn't burdened by unnecessary financial surprises, or even worse, collections calls for something that really should have been covered all along.
Okay, so the core of this whole kind of opaque system really boils down to messages delivered through these denial codes. What exactly are they, and why are they so fundamental to understanding this whole process?
Well, think of them as the universal language spoken between the payers, that's your insurance companies, Medicare, Medicaid, and the providers, your doctors, hospitals, clinics.
The translators, basically.
Exactly.
Yeah.
When a claim for a service you received isn't paid as expected, these codes are the standardized, sort of succinct way of communicating why.
Oh, okay.
They're like the error messages of the healthcare world. They quickly pinpoint why a service wasn't covered or why it wasn't paid in full. It saves everyone involved a lot of guesswork and, frankly, those really frustrating phone calls trying to figure things out.
Right. Try to get a straight answer.
Yeah. Without these codes, resolving a billing issue would be like, I don't know, solving a puzzle with half the pieces just missing.
In this language, it seems like one big confusing block, but you're saying it actually breaks down into two main categories, each with its own purpose, but they work together.
That's right. They work hand in hand. First, we have Claim Adjustment Reason Codes, or CARCs, C-A-R-C.
Circuits, okay.
You can think of these as the what happened codes. Their job is to explain why a claim, or maybe just a single line item within that claim, was paid differently than expected, or maybe why it was entirely denied.
So the basic reason.
The basic reason, exactly. And CARCs cover a really broad spectrum, everything from, say, contractual adjustments, where the provider has agreed contractually to accept a lower payment from the insurer, all the way to full denials, because a service simply isn't covered by the policy. They can also indicate edits that were applied by the payer, basically flagging discrepancies between what the provider sent in and what the payer actually processed.
Okay, so that's the what. What's the other category?
The second category is Remittance Advice Remark Codes, or RARCs. RARR.
Got it.
Now, if CARCs are the what, ARCs are more like the why it happened or maybe what else you need to know. Codes, they provide that crucial supplemental detail or maybe alerts related to the adjustment reason given by the CARC.
So adding more color to the story.
Precisely. For example, RSC might offer extra context about specific coverage exceptions. Or it might tell you that, hey, you need to send in missing supporting documentation. Or it could even alert you to compliance with new regulations. And a really relevant example, something that really grounds this in practical application for you, the listener, is how ARCs can be tied to legal notices,
Huh.
especially under the relatively new no surprises rules.
Ah, okay. I've heard about those.
Right. Those rules aim to protect patients from unexpected out-of-network bills. And ARCs can be used to communicate how a claim is, or maybe isn't, adhering to those specific regulations.
So the RSC gives you that extra layer of
Yeah.
information.
Exactly. So while a CARC might tell you flat out, service denied,
Mm.
the accompanying RC might explain why due to a very specific policy detail, or maybe a legal requirement like those no surprises rules. It adds necessary nuance.
Okay, so CARCs are the what? Our ARCs are the vital why, or the extra info behind it all. This is where it gets really interesting, I think. Let's unpack some of these CARCs. Some of them might seem, pretty straightforward, but others reveal these fascinating insights into that intricate dance of medical billing.
Mm-hmm.
And understanding them can really be an aha moment for anyone who's ever just stared at a medical statement completely baffled, like our friend Sarah trying to figure out her bill with that CR15.
Absolutely. Let's dive into some specifics.
Yeah, let's systematically go through some of the most common and frankly impactful CARCs and really connect them to real-world situations you might actually encounter.
Sounds good. And it's critical to highlight, as you said, how these connect to your experience. So let's start with the codes that most directly impact your wallet. Those related to patient financial responsibility.
Okay, the ones that tell you you owe money.
Pretty much, yeah. These are typically the first thing a patient notices on their explanation of benefits, that EOB statement explaining what was covered and what you might still owe. Or, if you're on the provider side, you see them on the electronic remittance advice, the ERA, which is just the digital EOB, basically.
Right.
First up, we have CRC, Deductible Amount.
Okay, the deductible. Everyone knows that one. Or thinks they do.
Exactly.
Yeah.
This code indicates that the amount stated on the line is being applied towards your annual deductible. Now, the real insight with CRER1 isn't just knowing what a deductible is, the amount you pay out of pocket before your insurance really starts paying its share.
Right.
It's understanding the widespread patient confusion it causes. This single code, CRRC, is honestly the root of countless patient phone calls to billing offices. It really highlights a critical gap in general patient financial literacy.
Which costs providers time and resources just explaining it over and over.
Immense time and resources, yeah. It's
Right.
fundamental to almost every plan, yet it remains this constant point of friction and confusion.
Okay, so CR ARC 1, that's your deductible. What's next?
Following that, we often see CR2, Coinsurance Amount.
Coinsurance. Okay, another familiar term.
Right. So once you've met that deductible, many insurance plans don't suddenly just start paying 100% of everything. That's a common misconception.
Yeah, you wish.
Exactly. Instead, they might pay a percentage, say 80%, and you're responsible for the remaining percentage, maybe 20% in this example. That remaining percentage you pay. That's coinsurance.
Okay.
So CRC2 means your coinsurance amount, that percentage, has been applied to that charge. The insight here is realizing your responsibility doesn't just vanish after the deductible. Coinsurance means you're still sharing the cost for the rest of the policy year, which can definitely be a surprise for many people.
Got it. So deductible first, then maybe coinsurance kicks in. What else?
And then there's CRC3, copayment amount. This one is perhaps the most familiar to many people.
Yeah, the $20 or $30 you pay right at the doctor's office.
Exactly. A copayment is that fixed upfront amount you pay for a covered healthcare service when you receive it, like that $30 for a doctor's visit you mentioned. CR3 simply indicates that this fixed copayment amount was applied and it's your responsibility.
Okay.
So these three codes, CR3, one for deductible, CRC for coinsurance, and CR3 for copayment, they're fundamental. They directly explain the most common reasons you might owe money after an appointment based on your plan structure. If you see one of these, you know it's a planned cost-sharing amount based on your policy.
Right. Those are the ones that relate directly to my insurance plan design. The direct hits to our pocketbooks, maybe the ones we sort of anticipate or at least can understand relatively quickly once explained.
Hmm.
But what about the more nuanced reasons, the ones that are often about maybe how the provider coded things incorrectly or perhaps some kind of administrative hiccup on the provider side? These might seem like provider problems, but they absolutely impact the patient. They can lead to you getting a bill you totally don't expect.
You're absolutely right. These can be far more opaque, much harder to understand from the patient's perspective. Let's move into those procedural and diagnostic inconsistencies. These often involve how services are described or justified in the claim, and they are, frankly, ripe for human error or system mismatches.
Okay, sounds potentially messy.
It can be. One of the most prevalent and honestly frustrating issues is CRC4, procedure code inconsistent with modifier.
Modifiers. Okay, you mentioned hieroglyphs earlier. This sounds like we're getting into them.
It can feel that way.
Yeah.
A modifier is typically a two-digit code that gets added onto a main procedure code. Its job is to provide crucial additional information about how or where or under what circumstances a service was performed.
Give me an example.
Sure. A modifier might indicate that a doctor only assisted in a surgery, they didn't perform the whole thing, that might be modifier 80. Or it might show that a procedure was bilateral, meaning it was done on both sides of the body, like both knees, that's modifier 50.
Okay, so specific details.
Very specific. Now, if the main procedure code, which describes the basic service, doesn't logically match the modifier used, or if the modifier is just missing entirely when one is needed, or maybe the wrong one is used.
And the whole thing falls apart.
Exactly. It can invalidate an otherwise perfectly legitimate service in the eyes of the payer. Imagine trying to describe a complex surgery to an insurer, but leaving out half the crucial details, or worse, providing the wrong context.
Yeah, they're not going to pay for that.
Right. This is a common, yet really critical error, and its frequency highlights the sheer complexity and level of detail required in medical coding. It's often a small error, maybe a typo, but has massive consequences, often leading to full denials that need to be corrected and resubmitted.
Wow. Okay, CARC4 modifiers. What else in this category?
Then there's CARS5,
Yep.
procedure bill type, inconsistent with place of service.
Place of service, like where it happened.
Exactly. This is about where a service was rendered versus how it was billed. For instance, maybe a complex surgical procedure that really requires an operating room in a hospital gets mistakenly billed as if it was performed in an outpatient clinic, or even just a regular doctor's office.
Why does that matter?
Because the reimbursement rates, the amount the insurance pays, and also the regulatory requirements for services can vary drastically depending on the setting, inpatient hospital, outpatient hospital, physician office, etc. These location errors are a common cause for denials because the billing doesn't match the reality of where the service took place. It speaks to the need for really precise administrative accuracy on the provider side.
Okay, so the what didn't match the where.
Right. And beyond just procedural errors, we also frequently see inconsistencies related to basic patient demographics. Simple stuff, but critical.
Like name and date of birth.
Exactly. But also age and gender mismatches with the services. So codes like CR6, procedure revenue code inconsistent with patient's age, and CRR7, procedure revenue code inconsistent with patient's gender. And similarly, focusing on the diagnosis side, CRR9, diagnosis inconsistent with patient's age, and CRR10, diagnosis inconsistent with patient's gender.
So what would trigger those?
Well, imagine billing for a pediatric vaccination for an adult patient, that's a CR6, or billing a gender-specific test, like a mammogram or a pap smear, for a male patient that would trigger CR7 or CR10.
Seems like obvious errors.
They often are. Usually simple clerical errors made right at the point of patient registration or during data entry. But there are immediate red flags for payers. The computers just kick them out instantly, causing the whole claim to grind to a halt. It really underscores how critical even that basic demographic accuracy is in medical billing.
Little details, big impact.
Definitely. Another important one related to who did the service is CRC8, procedure code inconsistent with provider specialty taxonomy.
Taxonomy, what's that?
It's basically a code that identifies the provider's specialty, like cardiologist, dermatologist, chiropractor, etc. CRRC, 8 flags, situations where the type of service billed doesn't align with the documented specialty of the provider who supposedly rendered it.
Like my chiropractor billing for heart surgery.
Exactly. That's the classic, maybe extreme example. Or maybe a dermatologist billing for a complex brain procedure. It would immediately raise a red flag. The insight here is the importance of a provider operating within their defined scope of practice and their licensure. Payers need to ensure the person performing the service is actually qualified to do so based on their official documented specialty.
Okay, makes sense. Check the credentials.
Right. And then there's CARC 11, diagnosis inconsistent with procedure. This one is absolutely key, and it tells a story about why the service was performed in the first place.
The justification.
Exactly. For an insurance company to pay for a procedure, the diagnosis code provided must logically support why that specific procedure was performed. It has to make medical sense. Okay, so if a patient is diagnosed with, say, a common cold, that's the diagnosis code, but the claim is submitted for an appendectomy, that's the procedure code.
Yeah, that doesn't line up at all.
Right. That's a clear inconsistency. The diagnosis has to justify the medical necessity of the procedure being billed. It's the story of why something was done, needing to match what was done. Without that logical connection, the service will likely be denied, because the payer simply can't understand the medical reason for the treatment based on the information submitted. I actually heard of a case once where a claim for, I think it was treatment for a sprained ankle, was accidentally submitted with the procedure code for an amputation.
Oh my goodness.
Yeah, obviously a typo, a huge one, but talk about a clear CR11 denial. The provider was mortified, naturally, but it just shows how easily one wrong number, one simple error, can completely derail the whole claim.
It's really incredible how many layers of validation are built into this system. It's not just about what was done, but who did it, where it was done, why it was done, does it match the patient's age and gender? So many checks.
There are. It's a complex web designed to prevent errors and fraud, but that complexity also creates many opportunities for things to go wrong accidentally.
Okay, now let's talk about those really frustrating administrative hurdles and information gaps. These often feel like simple paperwork issues, maybe a missed checkbox somewhere, but they can be major roadblocks to getting claims paid. And these are probably some of the most common reasons someone like Sarah gets that confusing bill with a denial code like CR15.
They absolutely can be, and you're right, they are incredibly common. One of the biggest, most frequent reasons for denial falls under CARC 15, missing incomplete information or submission errors.
The famous CR15 from Sarah's bill.
That's the one. This is truly a catch-all code, and it's consistently cited as one of the most frequent reasons for denials right across the industry. So when Sarah sees CARC 15 on her EOB, it's a signal that something fundamental, something required, was missing from the claim when it was sent.
But what kind of information? It sounds so broad.
It is very broad. The breadth of what missing information can mean is vast. It could be incorrect patient demographics, maybe a typo in the address, a wrong date of birth, an incorrect insurance ID number.
Simple typos.
Simple typos, yes. Or it could be missing or incorrect coding for the diagnoses or the procedures themselves. Maybe a required code was left off entirely. Or, and this is common too, it could be a failure to attach necessary supporting documentation that the payer specifically requested or requires for that service, things like clinical notes, medical records, lab results.
So it could be anything from a small detail to missing proof.
Exactly. And because CARC 15 is so broad, it often requires the provider's billing staff to do some digging, maybe call the payer, to figure out the exact missing piece. This obviously leads to delays and rework for the provider and potential confusion and delayed bills for the patient.
Okay, CARC 15, the big catch-all. What else?
Then we have CARC 29, filing limit expired. This is a critical one, particularly impacting providers, but it affects patients too if the provider can't bill insurance.
Filing limit, like a deadline.
Exactly. Insurance companies have strict time frames known as filing limits within which a claim must be submitted after a service is rendered. This window could be, say, 90 days from the date of service, maybe 180 days, sometimes even a full year, depending on the payer and the contract.
And if they miss it?
If a claim isn't submitted electronically or on paper within that specific window, even if the service was perfectly legitimate, medically necessary, everything else correct, it will be denied with CARC 29, purely because it was late.
Ouch. Why does it happen?
It could be due to administrative delays within the provider's office, maybe backlogs in coding or billing, or sometimes just simply overlooking a deadline for a particular payer. The consequences of missing these deadlines can be really significant, often resulting in totally lost revenue for the provider because these timely filing denials are notoriously difficult, often impossible to appeal successfully. The payer just says, sorry, you missed the deadline.
Wow, so timeliness is key.
Absolutely critical. Next is CR 30, eligibility not met. This code explains situations where a patient might appear to have insurance coverage on the date of service, but they're not actually fully eligible for benefits under that specific plan yet.
How does that happen?
Common examples include maybe a waiting period for new employees before their company's health benefits fully kick in. Or sometimes for certain Medicaid programs, there might be a spend down requirement, meaning the patient has to incur a certain amount of medical expenses out of pocket first before their full Medicaid coverage becomes active.
So they have a card, but it's not fully on yet.
Essentially, yes. It means the patient technically has a policy, but the specific service they received isn't covered yet according to the plan's rules or waiting periods. This really highlights the critical importance for providers of verifying not just active insurance, but actual eligibility for benefits before delivering non-emergency services.
Good point. Verification versus eligibility.
Right. And related to that, there's CR 31, patient not identified as insured. This is even more fundamental. It's a basic verification failure.
Meaning the insurance company has no record of them.
Pretty much. It means that when the provider checked or when the payer processed the claim, they couldn't confirm that the patient had any active insurance coverage with that specific payer for the date the service was provided.
Why would that happen?
Could be outdated information provided by the patient, maybe their coverage genuinely lapsed, or it could just be a simple data entry error when the patient's insurance details were put into the provider system. It's that basic validation that, when missed or incorrect, just halts the entire process right at the start.
Okay. And you mentioned one more in this administrative bucket.
Yes, CARC 35, lifetime benefit maximum reached.
Lifetime maximum. Do those still exist? I thought healthcare reform got rid of those.
That's a common thought. The Affordable Care Act did eliminate lifetime dollar limits for most essential health benefits on major medical plans. However, lifetime limits can still exist for certain types of benefits that aren't considered essential, or sometimes on older grandfathered plans, or even for specific services like, say, physical therapy visits per year, or sometimes dental or vision benefits might have annual or lifetime maximums.
Okay. So not for everything, but still possible for some things.
Exactly. So if a policy does have a cap on the total amount of money it will pay out over a patient's lifetime for certain specific services, and the patient reaches that financial limit, any further claims for those specific services will be denied with CARC 35. While less common now for primary medical benefits, it's still something to be aware of, especially for ancillary or specialized benefits.
That's a lot of ways for just the basic information or timing to be off, often leading to delays and major headaches for everyone.
It really is. Administrative accuracy is paramount.
Now, let's shift gears and explore perhaps the most contentious reasons for denials. Those related to coverage limitations and, the big one, what's deemed medically necessary. These are the ones that can feel truly adversarial sometimes, impacting what services we can actually access, and often sparking some pretty heated debates between patients, doctors, and insurers.
Indeed, host. These codes often lead to the most frustration, the most confusion, and certainly the most disputes for both patients and providers alike. This is where clinical judgment really meets the payer's rulebook.
Okay, let's get into it.
First, let's look at CHR 45. Exceeds fee schedule maximum allowable.
Fee schedule. So what the insurance thinks the service is worth.
Essentially, yes. Payers, the insurance companies, have pre-negotiated rates with providers who are in their network. Or, for out-of-network providers, they have internally determined rates for specific services based on geographical area or other factors. This is their fee schedule or their maximum allowable amount they will pay for a given procedure code. Now, if a provider charges more than this agreed-upon or allowed rate for that service, the payer will only pay up to their maximum allowable amount. The excess amount, the difference between the provider's charge and the payer's allowed amount, will be denied with CARC 45.
And who pays that difference? Does the patient get stuck with it?
That's the key question. The insight here is recognizing that healthcare isn't a simple price tag. What happens to that excess amount depends crucially on the provider's contract with the payer. If the provider is in-network, usually their contract requires them to write off that difference as a contractual adjustment. They can't bill the patient for it.
Okay, that's good for the patient.
It is. However, if the provider is out of network or in some other specific situations, that excess charge denied by CARC 45 could potentially become the patient's responsibility. This is one way balanced billing can occur, leading to those unexpected, sometimes large, bills.
So CARC 45 is about the difference between what's charged and what's contractually permitted or allowed by the payer.
Right. Understanding your network status is key there. Absolutely critical. Now, for a very significant and often highly disputed code, CAR 50, service not medically necessary.
Ah, the big one. The ultimate judgment call, it seems.
It really is. When you see CR50 on your EOB, the insight isn't just about the payer's definition. It's about recognizing this as a potential battleground where the clinical judgment of your doctor meets the specific protocols and guidelines of your insurance company.
So the insurance company's saying, we don't think you needed that.
Essentially, yes. It means the payer has reviewed the claim, possibly the submitted medical records, and determined that, based on their specific clinical guidelines, which can vary from payer to payer, the service provider was not considered essential, appropriate, or justified for the diagnosis or treatment of your specific condition according to their rules.
But my doctor thought it was necessary.
And that's the conflict. The real takeaway here is that medical necessity is often a subjective and, frankly, evolving target. It's defined differently by various payers using different criteria sets. This makes CARC50 denials prime candidates for patient-initiated appeals, often with strong support from the physician. It's also a key area where the provider's documentation needs to be absolutely impeccable to clearly justify why the service met medical necessity criteria.
So this code challenges the fundamental reason for the treatment itself.
Exactly. Makes it one of the most difficult, but often one of the most important denials to fight if you and your doctor believe the service was truly needed.
Okay, medical necessity, CRARC50. What else falls into this coverage challenge category?
Another critical administrative hurdle, but one tied directly to coverage approval, falls under CR62. Missing or exceeded pre-certification authorization, also known as prior authorization.
Ugh, prior authorization. That sounds like a nightmare.
It can certainly feel like one for both patients and providers. For many expensive procedures, like surgeries or advanced imaging like MRIs, certain specialized medications, durable medical equipment like wheelchairs or oxygen, or specific types of therapies like extensive physical therapy, insurance companies require the provider to get prior authorization or pre-certification.
Approval beforehand.
Exactly. It means the provider must submit clinical information and get explicit approval from the insurance company before the service is rendered or the prescription is filled.
And if they don't, or they do it wrong,
if this authorization isn't obtained beforehand, or if the service provided goes beyond the scope or duration that was originally approved in the authorization, maybe they were approved for 6 physical therapy visits, but provided 8 P4, the claim will be denied with CR62.
so no off, no pay.
Pretty much. This code emphasizes the absolute critical importance of navigating the prior authorization process correctly. Failing to do so is a near guaranteed path to denial for those services that require it. For you as a patient, this means it's always a good idea to proactively verify with your provider and maybe even your insurer that the necessary prior authorization has been secured before you have that expensive procedure or start that costly medication. Don't just assume it's been handled.
Good advice. Double check the prior auth.
Definitely. Then there are some simpler, more straightforward coverage denials, like CARC 96, non-covered charges.
Non-covered. Sounds simple enough.
It usually is. This means the service you receive simply isn't a covered benefit under your specific insurance policy at all, period. It might be something considered purely elective, like cosmetic surgery perhaps. Or it could be a specific type of treatment or test explicitly excluded by your plan's benefit document. The insight here is really about knowing your policy. You need to thoroughly understand your plan's exclusions before receiving services, if possible, to avoid surprises.
Read the fine print, basically.
Essentially, yes. Closely related, conceptually, is CARC 97, included in another services payment.
Included. What does that mean?
This refers to a concept called bundling. Insurance companies often bundle together multiple related services or procedures into a single payment for a primary service.
Like a package deal.
Exactly like a package deal.
Yeah.
For instance, the payment for a major surgical procedure might be considered by the payer to already include payment for all the routine preoperative assessments conducted right before the surgery, or maybe all the standard post-operative follow-up visits within a certain time frame, say 90 days after.
Okay.
So if those included services, the pre-op check, the post-op visits are billed separately by the provider. In addition to the main surgery code, they'll likely be denied with CARC 97. The payer is saying, nope, payment for that is already accounted for. It's bundled into the payment for the main service.
It's like buying a combo meal at a restaurant and then also trying to pay separately for the fries and drink that came with it.
That's a perfect analogy. The insurer says, no, that's already part of the main dish price. Understanding bundling is key for providers to bill correctly, and for patients to understand why certain charges might disappear or be denied on their EOB.
Okay. And you mentioned one more.
Yes, finally, CIRC 109. Service not covered by this payer, resubmit to correct one.
Ah, send it to the wrong place entirely.
Exactly. This means the claim was submitted to the wrong insurance company. Maybe you recently changed insurers and gave the provider old information. Or maybe there was a mistake in identifying your primary versus secondary payer if you happen to have multiple insurance policies. It's a fundamental error in just getting the claim to the right destination in the first place. The good news is, usually, this just requires resubmitting the claim to the correct insurance company.
So fix the address and resend it, basically.
Pretty much. Now, this list, as comprehensive as we've tried to make it, it's important to remember it's not exhaustive. The world of CARCs is vast. There are literally hundreds of these codes.
Hundreds, wow.
Oh, yes. But these examples we walk through provide a really representative look at the types of reasons a medical claim might be adjusted or denied. They give you a solid foundation for starting to understand your own statements. The key isn't really memorizing every single code number.
Right.
It's about recognizing the categories of problems they represent. Is it cost sharing? Is it a coding error? Is it missing information? Is it a coverage issue? Is it prior auth? That helps you know where to start asking questions.
That makes sense. Focus on the category of the problem. So, okay, we've gone really deep into the what's of denials with all those CARCs. If CARCs tell us what was denied or adjusted, you mentioned ARCs earlier, those are the helpful side notes, right? Giving us more of the why or that crucial extra context.
Exactly. Think of ARCs as the footnotes that clarify the main point made by the CARCs. And sometimes, honestly, those footnotes contain some of the most important information for understanding the full picture or what to do next.
Like the fine print that actually matters.
That's an excellent analogy. RCs really do provide that crucial supplemental detail. Think of them as adding the narrative behind the code number. They can specify unique coverage exceptions under your plan. They might indicate exactly what piece of supporting documentation is missing, unlike the broad CR15, or they can even provide important alerts regarding legal compliance.
Okay, so they add specifics. Can you give us a concrete example? You mentioned one tied to the no surprises rules earlier.
Yes, that's a perfect example of a RC providing critical context, RRC N876. This code is interesting because it's not really indicating a denial or a payment adjustment itself. Instead, it indicates that while coverage for a service is present, that coverage determination is accompanied by certain important legal notices related to surprise billing.
Ah, okay, so it's informational.
Highly informational and really important. Now, as we discussed briefly, the No Surprises Act is a significant, relatively recent federal law designed to protect patients like you from getting those shocking, unexpected bills from out-of-network providers or facilities, especially in emergency situations, or when patients don't really have a choice about who provides their care, like an out-of-network anesthesiologist during an in-network surgery.
Right, trying to prevent those horror stories.
Exactly. So seeing RRC N876 on your EOB isn't a denial, but it's an incredibly important piece of information. It's the payer essentially communicating that your bill is being processed under the considerations of these rules, or that certain notices related to your rights under the Act are applicable or being provided elsewhere.
So it grounds that technical RRC code in a tangible benefit to me, the patient. It gives me transparency about my financial protections.
Precisely. This specific RC tells you that the payer is explicitly acknowledging and communicating something about the legal framework governing your bill related to surprise billing. It helps ensure you aren't blindsided by a large, unexpected charge that the law might protect you from. It's a RRs acting as a helpful signpost pointing towards your rights.
That's a great example of how ARCs add that crucial extra layer. So, okay, we've walked through a ton of these CRX in our codes. Out of all of those potential reasons for denial, do some patterns emerge? Are there certain codes that just pop up way more often than others, causing the most common headaches for providers and indirectly for us patients?
Oh, they absolutely do. While there's that vast array of denial codes we talked about, industry guides, provider surveys, billing analyses, they consistently show two specific CRK codes rising to the top of the list as the most frequent reasons for initial claim denials. They represent persistent challenges for efficient billing and, ultimately, for patient clarity.
Okay, lay them on us. What are the top two culprits?
The first one, and we touched on this already, but it really bears repeating because of its frequency, is CIRCs 4. Missing correct modifier.
Back to the modifiers.
Back to the modifiers. It is consistently cited in industry guides as one of the top reasons for denials. It can account for a really significant percentage of initial rejections for many practices.
Why is it so common, just forgetting them?
It often happens because, as we discussed, modifiers are highly specific and very context dependent. A modifier might change based on the exact anatomical site of a procedure, or whether it was the only procedure done that day or part of a multiple procedure session, or if some unusual circumstance affected the service provided. Forgetting to add a required modifier or accidentally applying the wrong one for the specific situation means the payer doesn't get that full, accurate picture of the service they need to process it correctly. So it often leads to an automatic denial pending correction. The sheer volume of available modifiers and their nuanced application rules makes this a constant challenge for medical coders, and it's a small error potential with big financial consequences.
Okay, CR4, modifier issues. What's the other really common one?
The second major culprit, and no surprise here given our earlier discussion, is CRNG15, missing or incomplete information.
The big catch-all again. Sarah's code.
That's the one. Again, we discuss this as a broad category, but its sheer frequency makes it a critical area of focus for anyone trying to improve the billing process. The volume of data required for a single medical claim is just immense.
What kind of things fall under this most often?
It could be something as simple as an incorrectly typed patient name or date of birth, or maybe an insurance ID number that's off by one digit, leading to a CARC 15 because the payer can't match the patient. More complex examples that are very common include not attaching specific medical records that are required by that payer to justify a particular procedure, or failing to include a required pre-authorization number on the claim form, even if the auth was obtained.
So simple clerical errors or missing paperwork.
Exactly. Because this CARC 15 category is so broad, covering everything from demographics to codes to attachments, it's a constant battle for provider billing departments to ensure every single required piece of information is accurate and complete on that first claim submission. It's often the frustrating paperwork problem that drives patients crazy when they get a denial, just like Sarah's initial mystery bill.
Gotcha. So CARC4 and CARC15 are the big recurring nightmares.
They consistently rank among the highest volume denial reasons. But what's important to remember, and maybe the silver lining here, is that these common patterns, especially CR15 and many CARC4s, are often preventable.
How so?
They really highlight areas where diligent attention to detail during patient registration, robust patient intake processes to capture accurate insurance info, thorough documentation by the clinician, careful coding, and maybe using claims scrubbing software before submission can make a profound difference. Investing in getting it right the first time can significantly reduce these common denials and improve the entire billing cycle for everyone involved. Less rework for the provider, faster payments, and fewer confusing bills for the patient.
So for me as a patient, just knowing that CARC4 and CARC15 are super common means if I see one on my EOB, I'm already kind of ahead of the curve in guessing what might be wrong.
Exactly. It gives you a starting point for the conversation with the provider's billing office.
Okay, this is great. So now we have this new superpower, maybe not X-ray vision, but the ability to understand these cryptic codes, or at least know what they generally mean when we see them on an EOB. But how do we actually use this knowledge? This raises the really important question. What can you, the listener, actually do when you encounter a denial? How can this knowledge empower you to navigate what often feels like a total black box and turn that frustrating problem into something solvable? Just like Sarah needs to do with her Sec 15.
Right. This is where understanding these codes moves from just theoretical knowledge to practical, actionable steps. They really do provide a roadmap for resolution and, hopefully, for future prevention or improvement.
Okay, so what's step one when I get an EOB with a denial code?
Step one is simply identify the codes. When you receive that explanation of benefits, EOB, from your insurance company, that crucial statement telling you what they processed, what they paid, and what they think you might still owe, look carefully. Or, if you happen to be a provider looking at an electronic remittance advice, ERA, which is just a digital EOB, these CR codes and any accompanying RRC codes will usually be clearly listed right next to the specific service line item that was denied or adjusted. They are your initial clues. The very first step in deciphering your bill is finding those codes.
Okay, found the code. Let's say it's CRRC15, like Sarah's. What's next?
Step 2 is map the code to the exact cause. This is where your newfound knowledge comes directly into play. So if Sarah sees CR15 on her EOB, she instantly knows the general problem is missing or incomplete information. She doesn't know the specific missing piece yet, but she knows the category. This knowledge allows for a much more targeted response. Instead of just guessing or making a frustrated call to the provider's billing office or the insurance customer service line and vaguely saying, my bill is wrong or you denied this, you know precisely why, at a high level, the claim was denied according to the payer.
So I can ask better questions.
Exactly. You can now ask specific informed questions, like, I see CR15 was applied to the claim for my visit on date. Can you tell me what specific information was missing or incomplete that caused this denial? That's a much more productive conversation starter.
Okay, so I've identified the code. I know the general reason. What's step 3?
Step 3 is work towards correcting the issue. Now that you know the type of problem, you or the provider can take steps to fix it. This might involve a variety of actions depending on the code. If it's CARC15, missing info, the provider might need to resubmit the claim with corrected patient demographics, or they might need to track down and submit a copy of medical records that the payer requested and didn't receive. You might even be able to help by confirming your current insurance details with them. If it was, say, PRTR4, modifier issue, the provider's coding team would need to review the service, add or correct the specific modifier, and then resubmit the claim to the payer. The code tells you exactly what kind of fixing needs to happen, which really helps streamline that often frustrating back and forth between provider and payer.
So the code points towards the solution.
It points towards the area needing correction, yes. Now, for providers especially, but even for individuals who are managing a lot of medical bills for themselves or their family, step 4 is really valuable. Track denials and root causes.
Keep a log, basically.
Essentially, yes. By recording which denial codes appear most frequently, either from a specific payer or for a specific type of service, you can start to identify patterns. For a provider's office, this is absolutely crucial. It helps them improve their overall billing accuracy and prevent those same denials from happening over and over again. They can address systemic issues. Maybe they realize they consistently make errors with a particular modifier, or they need better training on a specific payer's prior authorization requirements.
And for me, as an individual,
For you, tracking can help you spot recurring issues too. Maybe you notice your specific insurance plan seems to deny claims with CR50, medical necessity, very often for a certain type of therapy. Or maybe you keep seeing CR62, prior auth the missing, denials originating from a particular specialist's office. That pattern might signal a need to be extra vigilant about prior auths with that specific provider, or maybe even consider if there are systemic issues with how they handle billing for your plan. Knowledge is power.
okay, track the patterns. What's the final step if correcting the issue doesn't work, or if I disagree with the denial?
Step 5, and this is a big one that people should know they have a right to. Appeal where appropriate. Not every denial is or should be the final word.
So I can fight back.
You absolutely can, and often should. If a service was indeed medically necessary according to your doctor, countering a CARC 50 denial, and you believe the payer's decision was incorrect based on clinical evidence, or if there was a clear system error, maybe a processing glitch led to a TCARC 15 denial even though all info was submitted, then appealing the decision is a legitimate and often successful part of the process.
And knowing the code helps with the appeal.
Tremendously. Your understanding of the specific denial code arms you with the exact reason you need to challenge. You can structure your appeal to directly address the CR code cited. You can articulate precisely why you believe that specific denial reason is wrong, providing supporting evidence, rather than just vaguely stating, I think this should be covered, or my bill's too high.
Can you walk me through a quick example of an appeal?
Sure. Let's take Sarah's CARC 15 again. If her provider's office investigates and finds out the denial was because a specific medical record needed for review wasn't sent, the first step is simple. The provider sends that specific record to the payer and asks them to reprocess the claim. That's usually not a formal appeal, just correcting the information.
Okay.
But let's say Sarah received a denial with CARC 50, not medically necessary, for a procedure her doctor strongly insisted was vital for her health. Now that calls for an appeal. Her first step would be to work closely with her doctor's office. They would need to gather compelling clinical documentation, maybe test results, physician notes, peer-reviewed articles, and crucially, often a formal letter of medical necessity written by the doctor. This letter would explicitly state why the procedure met the standard criteria for medical necessity for her specific condition, directly countering the payer's determination.
So gather evidence.
Exactly. Then Sarah, often with help from her provider's office, would formally submit this package of evidence to the insurance company's appeals department, following their specific process and deadlines. Payers typically have multiple levels of internal appeal, and if all internal appeals are exhausted and you still disagree, you usually have the right to an external appeal, where an independent third-party reviewer, not affiliated with the insurance company, looks at your case.
Wow. Okay, so there's a whole process.
There is. The key is persistence, providing clear, documented justification, directly addressing the denial reason, and knowing your rights to multiple levels of review.
That's incredibly helpful. Beyond just reacting to denials, are there proactive things I can do armed with this knowledge?
Absolutely. Proactive measures can save a lot of headache later. First, as we mentioned, before a significant service, especially an expensive one or one likely to need prior auth, always try to verify your insurance coverage and benefits yourself directly with your payer. Don't just rely on the provider's office verification. Double-check it yourself if possible. Ask your insurer explicitly. Is prior authorization required for procedure code? Get the code from your doctor. And if it is, confirm with your provider's office that they have indeed obtained that specific authorization before your appointment date. Get the authorization number if you can.
Be proactive about the paperwork.
Yes. And don't be afraid to ask your provider's billing office questions up front. You could ask about their typical process for submitting claims to your specific insurance, or even inquire, politely, about what their average denial rate looks like for your plan. It shows you're an informed patient. Understanding these proactive steps, combined with knowing how to react to denials using the codes, can lead to much faster resolution of any issues that do arise. It gives you a clear understanding of why a bill looks the way it does, and ultimately, this proactive and informed approach can save you immense stress, valuable time, and potentially a significant amount of money that you might otherwise have paid out of pocket for services that actually should have been covered by your plan.
That's really empowering. Okay, so if this deep dive has really sparked someone's curiosity and they want to explore even further, maybe look up specific codes themselves, where should they go? Are there good resources out there that delve even deeper into this labyrinth of codes?
There absolutely are. For anyone wanting to truly dig into the most authoritative official sources, the place to start is the X12 organization.
X12.
12 is the standards body that actually develops and maintains the official code lists.
X12, okay.
Yes, they maintain the full, official, and most up-to-date listings of both the CIT codes and the RIRC codes. This is the ultimate primary source for their precise definitions and usage guidelines. You can usually find these lists on the X12 website, often in downloadable files like spreadsheets or PDFs. Now, fair warning, it's a technical document designed more for implementers, but it is the definitive reference.
Good to know where the ultimate source is. What else?
It's also really worth noting that sometimes state Medicaid programs or even specific individual insurance payers might have unique error codes they use internally, or they might have very specific interpretations or documentation requirements that go beyond the general X12 list.
So it can vary by state or by plan?
It can, especially for state-run programs like Medicaid. For example, the source material mentioned Utah having specific lists other states might too, or a large commercial payer might publish its own billing guidelines that specify exactly which documents they require to avoid a CARC 15 for certain procedures. So if you're dealing frequently with a particular state program or a specific health plan, it's always a good idea to check their provider portal or website for any payer-specific guidelines or code lists they publish. These are usually available online.
Check the local rules, basically.
Exactly. And then, for more user-friendly guidance, something maybe less technical than the raw X12 lists, there are many excellent industry summary guides available. These are often published by healthcare technology companies, billing services, or healthcare consulting firms.
Like who? Any examples?
The source material mentioned SPRY-PT, Adonis, and Conifer Health Solutions as examples. There are many others out there as well. These companies often create simplified breakdowns of the most common CRRC codes. Crucially, they often include practical resolution tips, explanations written in plainer English, and maybe even flowcharts for how to address specific denials. They make the complex information much more accessible.
So they bridge the gap between the technical code and what I actually need to do.
Precisely. For instance, one of these guides might offer a step-by-step flowchart for appealing a CANT R50 medical necessity denial, suggesting the types of documentation to gather. Or they might provide specific questions you can ask or scripting you can use when calling your insurance company about a confusing CANT 15 denial. They really bridge that gap between the technical code itself and the practical action needed to resolve it. They can be invaluable for quicker reference and understanding.
Fantastic. So lots of resources available, from the super technical to the more practical guides. Okay, let's try and bring this all together. To quickly recap this fascinating journey through denial codes, We learned that CARCs, the claim adjustment reason codes, they tell us what was adjusted or denied on our medical claim. They give us that primary reason for the discrepancy in payment.
Right. A what?
And then the R-CARCs, remittance advice remark codes, they come in to provide the crucial why, or that important additional context. They add layers of detail to those adjustments, like that really important example of R-CAR N876 signaling information about the no surprises rules.
The why and the what else?
We also really highlighted those common pitfalls, didn't we? The ones that seem to trip up both providers and patients most often, like missing or incorrect modifiers, that troublesome Coke 4, a tiny error potential with big consequences.
A constant headache.
And that broad category of incomplete information, our friend CARC 15, the likely culprit behind Sarah's initial confusion, just knowing that these two are the most frequent reasons can really help you zero in on potential issues right away when you look at your EOB.
Definitely gives you a head start.
And fundamentally, I think we've reinforced the idea today that understanding these codes, even at a basic level, truly empowers you, the listener. It helps you become a more informed, more active participant in your own healthcare journey. It transforms that feeling of confusion and helplessness when looking at a bill into clarity and the ability to take action. You're no longer just passively receiving a bill you don't understand. You're actually equipped to understand it, question it, and act on it.
That's exactly right. And if we connect this to the bigger picture, the ability to decipher these codes, it really transforms what feels like a frustrating, opaque process into one where you can be proactive. You can help prevent denials by asking the right questions up front. You can work with your provider to ensure claims are corrected efficiently if they're denied. And ultimately, you can advocate for proper revenue recovery, whether that's directly for a healthcare provider, ensuring they get paid fairly for their services, or indirectly by ensuring that the services you received are properly accounted for on your own bill and covered appropriately by your insurance plan, minimizing your out-of-pocket costs.
It really shifts the power dynamic a bit.
It does. So consider this as a final thought. In a system as incredibly complex and, frankly, as financially significant as healthcare, isn't understanding this language of denial, these CARCs and ARCs, isn't that one of the most powerful tools available to us? A tool for fostering transparency, for ensuring accountability, and for making sure that the services you receive are properly accounted for and ultimately paid for correctly without those stressful, unnecessary surprises. It truly puts more power back into your hands as a patient or consumer, allowing you to advocate much more effectively for your own financial health in a system that, let's be honest, often feels intentionally designed to confuse.